Nice
cover
presentation and
those.
nice display of cases. Just one comment for especially for beginners. Now, for in accessory pathway ablation, whether it is left side or anywhere else, it is very important that you map a lot and then ablate only once or twice. And so my policy is that if the pathway, when you are starting RF ablation and you don't eliminate the pathway within 5 seconds, I'd stop the burn. Especially for left-sided pathways, if you give multiple long duration burns, it what happens is your pathway has not gone, and but there is development of edema. And then subsequent RF ablation, even if you are at the precise location, they don't eliminate the accessory pathway conduction because of the effect of edema. It prevents the energy from reaching to the desired site. So that's very important that you should not go on ablating. And if the pathway does not go within 5 seconds, Dr. Lawrence said 10 seconds, I even a more stricter. And so if it doesn't go in 5 seconds, you stop the application and then do more mapping. The other thing is accessory pathway potential. Although some of the ablationists, especially Dr. If you listen to Jackman, they will never ablate unless they see an accessory pathway. However, due to limited time and the patience that we have, we hardly actually, even if we see a potential, we don't actually validate it to be accessory pathway potential. So ideally, what one should do is, if you see a accessory pathway potential, you should validate and confirm that it's accessory pathway potential by doing pacing maneuvers, by programmed stimulation of atria and ventricle. And so when you have AV block, we should see that the atrial signal is different from the accessory pathway potential. Similarly, when you have VA block, you should show that the pathway block, and so your pathway potential is not the part of A nor the part of V, and it's a separate location. And if you have a ablation catheter at that precise site, and if you ablate, give an RF application there, there's very good chance that you are going to get the pathway within very few first 2 or 3 seconds itself, and with very low risk of a recurrence in such situations.
Yes, beautiful points. I think particularly in the early days of your career, when you see a signal which is reasonably fused, we tend to go. I think it's a fused signal is I should say it's a misnomer. You need a early A or early V. Sometimes, particularly when you increase your gain settings because you're not having a good contact, all the signals which you see look fused. So if you go on ablating, you ultimately end up, one is a edema, second is a isthmus block, and you would have completely screwed up by now. And moreover, you would have been tired by now. So as clearly told by Dr. Bhargav, you map more and more and ablate less. I think your ablation should be minimal. If the pathway does not go in 5 seconds or 10 seconds, then you are not on the pathway, and map more and ablate rather than go on ablating. Dr. Parag, any points from your side?
Yeah, I completely agree with you both. Like in the early part of the career, when you have a nice and closer signals, you're so much tempted to basically ablate because you feel that this is going to go there. And then you actually end up doing ablations, and then edema sets in, and then your total procedure is gone. So there are certain things which for the early beginners that they should actually be able to understand what is a near field signal and a far field signal, and what is the A and the V ratio while they're ablating the pathways. So what we feel that A and V both should be like equal to each other, or probably we should have as close as A and V so that we get a successful ablation. But the real actual crux is that you should predominantly be on a ventricular aspect, because that is the thinner part of the pathway, because the ventricular insertions are the weaker insertions. So basically, if you have a smallish A, larger V, but the both signals needs to be near field, rather than having a far field and a blunt signal. If you have a sharp signals, smaller A, bigger V would give you a better results of actually the radio frequency ablations of the pathway on the right side or a left side. So that is one thing which I would like to bring to your notice, that first of all, everyone who's doing, and the early beginners or the fellows who are now starting their career, they should be able to understand that there is something called as a far field signal and a near field signal. And every signal where you are going to ablate, your ablation signals, the distal ablation signals, should have the nice near field signals, which are sharp signals. Even a small A, large V, and a close AV association would be a very good site for ablation. And if you're not getting that separation, or if you're not getting that going away of the pathway connections, you should just stop before 10 seconds. 10 seconds. Some few people consider within 3 seconds exceptional ablation, 3 to 5 seconds fair ablation, up to 10 seconds acceptable ablation. More than 10 seconds, it is not acceptable because the pathway is somewhere else. The heat has now translocated to that area and the pathway has gone transiently and is going to come back. So 10 seconds should not, after 10 seconds, we should actually discontinue our ablation. So another point which I would like to say, that in my practice, what has changed over a period of last 2-3 years is that I've stopped using a retroaortic approach, because first of all, your stability of your catheters, you usually don't have a bidirectional ablation catheter, which gives you some more benefit as compared to unidirectional ablation catheter. So I have changed completely to a transeptal approach. Third thing, as Dr. Lawrence has also said, like I've also shifted to almost 100% on a 3D, because you try to do ablation while it is in tachycardia. Definitely you'll keep a V-pacing catheter at a 10 or 20 milliseconds faster than the tachycardia cycle length for a backup pacing as soon as the tachycardia terminates, because that gives you that stability of that catheter at the same site. But still you will have microscopic movement when the tachycardia terminates, and your catheter will be away from your actual site of ablation where you need it to be. So in 3D, you know that when you are ablating, and even if there is an movement or a brisk movement of the heart, you will actually go to the same place again and you will be able to ablate it. And the best part, which Dr. Lawrence has said, that consolidation burn is like, you know that here your burn is successful. Go 2 to 3 milliseconds above, below, lateral, and medial. Give 3 or 4 consolidation, but your chances of recurrence will be slightly lower. So these are all things which we should know, and we should more and more try to do that. More to map, less to ablate in pathways. And even in AV&RT also, that the principle holds true. And that is what I would like to say from the left lateral pathway, that I have changed specifically completely to the transeptal approach and completely a 3D approach.
Thank you. Thank you. Do we have Dr. Rohan online, or signals are lost?
I agree with everyone that mapping is very, very important, because without a proper map and when you have proper signals, if you go, you're going to cause edema and you're going to just lose.
I think you lost him again. Dr. Bhargav, small question to you. I think when you stop at 5 seconds, do you allow your power to reach and you count 5 seconds? Because there are times when you started ablating, your power has not reached. Maybe around, you would have touched 25, 30, 40 watts and you would have reached 5-6 seconds. How you calculate this 5 seconds? After your full power has reached, or reasonable power has reached 5 seconds, or how it is?
Yeah, so that's a very good question. So your power should reach within the first 2 or 3 seconds. So I count from the start of my RF application. And if your power is not reaching within 3-4 seconds, then there is no point actually delivering, even if you have ablated, because then the chances of recurrence even during the procedure itself is very high. So if your power is not going up more than 20, up to 20 is actually quite good when you are using a non-irrigated catheter. And especially it happens when you are doing through a retrograde approach that we actually use in most of our patients. If you are below the valve, when your ventricular signal is large and atrial signal is very small, and the blood flow is actually lower at that side, the stability is actually quite good. And but sometimes because of the poor blood flow in that location, your power may be limited by the temperature, and so you may have to move the catheter a little bit so that you can deliver the RF with enough power. But if you're not successful, you may have to use an irrigated catheter in that situation, or you may have to go on the atrial side. But I count from the moment we start the RF application.
I think we have got Dr. Rohan back. I think
Yeah, sorry. Yeah,
signals
I
are
got
okay.
disconnected.
Your final comments, sir. Yeah.
Well, I don't think there's nothing much to say, but I agree that a lot of the speakers that when you come to the left-sided path, this transseptal approach is the best because you have much more control, and we don't usually use 3D mapping in our setup for most of our lateral path, the left lateral pathways. We do still go conventionally, and it is something I think that the trainees must learn, because when we rely too much on 3D mapping, we kind of lose the kind of the fun of the real EP mapping, which is really actually by the electrical signals. So we should not forget about that.
Yeah, very true. I think we had an excellent discussion and wonderful talk and inputs from all our moderators.
Dr.
To add
Lawrence,
on,
can
Dr. Rohan, yes, definitely. I think in the early part of your career, I think when you are in a fellow in training or in the early part of career, I think you concentrate with your signals more, even though you have 3D mapping available. I think once you get in good control of your mapping and signals, I think 3D mapping will allow you a better results, maybe. Dr. Parag, you wanted to add something?
Yeah. So, Dr. Lawrence, regarding the posteroceptal pathway, I just wanted to bring into the notice of all the viewers as well as to the younger generation, because left posteroceptal pathways are pretty like they're very unique variety of pathways. Many a times you will be able to actually ablate them from the right side going into the coronary sinus. So it becomes sometimes very difficult for you to actually make a decision whether to do a transeptal, go into that posteroceptal gutter region and ablate from the left side, and or else you go into the coronary sinus and do a very brief ablation in the mouth of the coronary sinus or within 1 or 2 centimeters of the coronary sinus. So decision of that lies completely with the individual operator, but you need to keep your mind completely open that even if you are going a transeptal and doing an ablation in the posteroceptal region on the left side, you're not getting a successful thing, you may actually come back onto the right side, go into the coronary sinus, and sometimes you may have to go into the middle cardiac vein also. These pathways you will have a R in V1 stating that they are a left-sided pathway, but still accessible from the right side. There are some varieties of left posteroceptal pathway, and specifically Dr. Lawrence has also said about the CS diverticulum type of pathway, but these are also like middle cardiac vein, CS diverticulum type of pathway. These are very unique varieties of pathways which can be ablated from both sides. They're actually a left-sided pathway, but accessible from the right as well as from the left.
Yeah, I think it's a wonderful point. I think one point to be added to all our fellows and early part of EP. I think your last option should be go into CS and ablate. I think when you see like the pathway is most probably from left side, never go into CS and ablate. Always try go left and map. If you don't find anything there interesting or it's not going off from the left side, then you come back to the right and ablate, because it's always tempting when you see your maybe early PCS, maybe early proximal coronary sinus signals may become very juicy, which are inside the CS, maybe 1.5 or 1-2 centimeter inside the CS may look juicy, but never use it as a primary technique to get into the CS and ablate. Always go on left side, map. When you fail, you can come back and try, because ablating into CS is dangerous also. I think you can it's not so vascular area. You can cause a serious complications. So there are times I've seen people primarily going into CS and ablate. All your pathways in left side also will look juicy in the CS signal sometimes. So you cannot go inside the CS and ablate. What Dr. Parag has explained is a unique situations where you will have gone left side, you tried, but you could not get it from left side, the posteroceptal area. Then you can come, because that trigone is very unusual area. You get a lot of varieties there. You can have a diverticulum, a pathway in the proximal CS, the pathway on the left posteroceptal area, right posteroceptal area, epicardial pathways all look nearly same in that trigone area of posteroceptal region. So when we, in a early part, you never go into CS as a primary option, always, but have in mind that there are pathways which are inside the CS which can be ablated inside the CS. They are not very common, but as a last resort, or you can map and find out if you are able to get it in the middle cardiac vein area or a proximal CS. I have ablated, I think, recently we had 2 pathways which are reasonably deeper inside the CS. I thought it could be a muscular sleeve which is going in, which has causing the pathway. I tried from everywhere, went left side, right side, everywhere, nothing, but went inside the CS with the irrigation, in 4 seconds gone. The pathway was a recurrent pathway, tried elsewhere twice. So there are pathways which are very uncommon. I think, like as Parag is saying, these are all what we are talking is about high volume centers where you are seeing once in 3 years, 4 years. So you don't feel this is a common one, and never get into CS as a primary mode of ablation. I think with this, we'll close the session and the topic. My sincere thanks to Dr. Narasimhan, I think, who is not able to join us because of his personal commitments, but a wonderful presentation. All our moderators, Dr. Karthikeya Bhargav, Dr. Gunavardhane, Dr. Parag, and Dr. Suresh. Dr. Suresh is joining in spite of his recent injury, and is on the way to Coimbatore for a treatment, but still he joined us. So many thanks to all of you for the wonderful discussion, and our technical team and Abbott for wonderfully organizing this, and all our audience for being part of it. I think we had one question in the chat box. I'll finish with that question. I think it was about duration of ablation. If you have a pathway gone in 5 seconds also, you have to consolidate. You have to give a full 120 seconds ablation. And if required, you may have to give a further consolidation if your lesions are not good enough, your impedance drop is not good enough, you give a good contact and deliver more, but not 5 seconds. You have to complete the ablation. And regarding CS ablation, jugular or femoral, it depends. There are times you may not be able to enter CS without effort inside by a femoral route. You can use jugular route also, but around 70-80% of the time you should be able to get into the CS by femoral route itself. So most of the CS OS ablations are also done by femoral route. I think with this we'll close the discussion. Thank you all.
Thank you.
Thank you for
Thank
being
you.
with us. Thank you. Thank you.